Thank you. It's great to be here. It's a great conference, Mark. I'm excited to be here because I know nothing about how to do anything in the laboratory. I'm an epidemiologist. I got into this field studying alcohol and HIV and how alcohol harms people with HIV especially. And I feel like behind me there's a whole crowd of behavioral researchers, some in HIV and some in related fields, really wanting to understand alcohol use and having years of relying on self-report. So there's, just so you know, there's tons of interest. I've been funded by NIH, and they're really interested in us getting better measures of alcohol use. I'm sort of representing them, so I've actually put in some plugs in the end for what we'd like to know. I'll do a little background. I'm going to talk about a brief alcohol intervention randomized controlled trial, the methods of the results, and what we found in the trial and what we found with underreport, summary and conclusions, and then our wish list for PEth and alcohol biomarkers going forwards. So for those of you who aren't aware, alcohol use affects HIV clinical outcomes in multiple ways. We call this the HIV cascade, from sexual risk behavior to biologic outcomes, including, sort of our goals. Our goal is HIV viral suppression, but then as the HIV epidemic goes on, co-infections and comorbidities are also important, and alcohol use affects many of those as well. So there is a desire to reduce alcohol use among people with HIV. Most people with HIV are in sub-Saharan Africa, where there are very limited resources, so there's a look for low-cost, low specialist type interventions. And so we started exploring brief interventions for alcohol use for people with HIV. We know that, overall, in primary care, brief interventions have been shown to reduce alcohol use by a small amount overall, but there's really mixed evidence for their efficacy in people with HIV, and very few of these studies have been conducted in persons in low and middle income settings. We also know that having multiple sessions is, regardless of length, is deemed to be the most effective way to do brief interventions. And so cell phone technology, this is Nelson Mandela with his cell phone, have been thought to be potentially useful for interventions. So to wrap up that background, there's a need for evidence on whether brief multi-session interventions for alcohol use in persons with HIV in low and middle income settings would be efficacious. So we did a randomized controlled trial. So these are not treatment-seeking people. They're not on the very high end. Well, most of them are not on the very high end of alcohol use disorders. They're self-reporting hazardous alcohol use using the AUDIT-C. They're all stably on HIV therapy, so they've been on for 6 months, and they're at patients at a local HIV, very large clinic where I have several collaborations. So we did a 3-armed trial with a control arm where the participants received only brief advice, an arm we called Lifecall, where they got 2 in-person counseling sessions at baseline and then at 3 months, and in between they got monthly booster phone calls from their counselor. And what we called the tech arm was they had the same counseling sessions, but to utilize the technology, we sent them booster sessions via either SMS, like text message, or IVR, which is a sort of recorded device for people who wouldn't be able to use SMS, because there are some literacy issues. This is, whoops. Okay. This is about the interventions. It had a workbook. It was developed and it had been used in other settings. It was adapted for the local setting with pictures. It's kind of a harm reduction type intervention. And I say the harm reduction because actually a lot of the data that we've been talking about have been from going into residential treatment or outpatient treatment to abstinence. This is no inpatient, and we're not really seeking abstinence, we're just trying to reduce the level. So I think that's interesting, and I'm curious about how PEth works in that setting. So an in-person session with Workbook, and I mentioned the booster sessions. Here's a chart of our study methods. We have the 3 arms. At baseline, we did questionnaire with timeline follow back. Says DBS collection for PEth. It was actually a venous blood draw that we pipetted onto the DBS. The PEth was done at US Drug Testing Laboratories. We also did viral load testing. The intervention or the control happened over 3 months, then we tested them again at 3 months, 6 months, and 9 months. Our a priori outcomes were both self-report and PEth. So the self-report outcome was using a timeline follow back, and we used number of drinking days in the prior 21. Reason for number of drinking days rather than drinks is it's pretty hard to quantify drinks in Africa. Number of drinking days is a pretty good correlate. And then we use PEth. We use this analog, etc., viral suppression, and then we did our analysis. Here's our consort diagram. I'm going very fast because I want to get to the PEth part. We did pretty well with retention. At baseline, whoops, sorry, you're not the only one. At baseline, about a third were female. We had some low literacy, pretty high viral suppression actually. When you look at their drinking, their AUDIT-C score that goes from 0 to 12, and we modified it for asking for the prior 3 months, was 8, and their PEth median was 259. These are interquartile ranges, not ranges, so our high end was quite high. One thing to notice, when you randomize, you hope that the 3 arms come out equal. We did actually have higher PEth levels and higher drinking days in the technology arm. So what were our results? This is the self-report result, where we see the 3 arms at baseline. The red is tech, the green is control, the blue is Lifecall. They all reduce their drinking over time, but there's actually a separation in that the control arm stays higher. Sorry about that. The control arm stays higher, and it's actually in our random effects model using the interaction terms, controlling for sex and baseline alcohol use. These are statistically significant differences. So we had done self-report, which is really what's out there in the literature for these types of interventions. We would say this is an efficacious intervention. Unfortunately, PEth told a different story, and you can see there's a little bit of differentiation. There's a pretty wide spread at baseline in the medians. These are 95% confidence intervals, but there's really not much of a decline, maybe a little bit at the end in that last group. And that's the Lifecall group, but it actually wasn't statistically significant. Here's a slide with too many numbers on it, but showing you the same picture. So then we started, for this meeting, I wanted to explore the underreport just a little bit further. And we divided the AUDIT-C and the PEth into 3 categories so that we could come up with categories for underreporting. And so we use some AUDIT-C categories defined here. These are fairly standard categories in the literature. In PEth, I've been using a cutoff of 50. We could discuss, but so that I really can denote what we call hazardous drinking. And then I was using the 200 of Orwelling for the high-risk group. So we had our 3 groups by each, and then we compared them. And when we compare them, we get this 2x2 table. So the green is the concordant, and here's the audit, the self-report, and there's the PEth. The green is concordant, and about 39% had concordant results. And this is at any visit. The blue is where the self-report actually exceeded the PEth level, and that made up about 16% of the observations. And then the yellow is where the PEth level exceeded the self-report, and that was 45%. And the really most significant group is here, is 125, where they, by self-report, fell into a low-risk group, but their PEth level was above 200. And that's, even if we only call that underreporting, it's still a rather large group. We looked at factors associated with this, and we found that as age increased, the odds of this underreport increased. As body mass increased, it went down, and maybe it wasn't underreport, that's probably more of a biological thing. The baseline PEth level was associated with increased odds of underreport. Being in the intervention arm, where you're being counseled to reduce your alcohol use, was associated with underreport, and also being in a follow-up visit versus a baseline visit, where you're in the study potentially trying to please the interviewer, whether you were in the intervention arm or not. So in summary, not surprising, the findings from trials may differ if PEth rather than self-reported is used as the outcome. I mean, that's not surprising to this room, but I think that in my field, people have been relying on self-report for so long, they need to see this. It seems it's definitely likely after receipt of a behavioral or maybe even pharmacological intervention and even after baseline in a study. We also found the BMI potentially being a biological factor that we've seen before, people with higher BMI having lower PEth levels. And this is sort of a question out there. Because PEth isn't completely sensitive, we've been thinking about, and a lot of the papers that I've written, we combine PEth with self-report so that if someone, in the setting that I'm working, over-report is not really a problem. So if someone says that they're a hazardous drinker but their PEth level is a little lower, we say, yes, you're a hazardous drinker. We don't really question their self-report if it's higher than their PEth. And I'm a little curious about the finding about why why we found the higher sort of, what I was calling underreported people with higher levels of PEth at baseline. I'm curious of what happens, if people are, they're not abstaining, but they're continuing to drink, and we're looking at their PEth levels. Is it going to go down the same way as when we're looking at people becoming abstinent? And that's why I asked that question earlier about people reducing their drinking. I don't know, because I can't trust the self-report in this study, but if we had a study where we could trust the self-report, really find the drinking going down but maybe not going to abstinence, I would love to see if PEth is eliminated the same way that it's eliminated when you actually stop drinking. So that's one question, and I'd love to hear people's thoughts about that. My wish from all those other researchers that are doing this type of work is, and probably not a surprise, but we'd like lower cost and faster. And then I'm curious about what's going on with other body fluids. I saw this, that study from 2015 in breath, and I got excited and then never saw anything else. So maybe other people know. I have colleagues. I should mention I have tons of DBS in the freezer at -80 and serum. So if you could figure out how to get PEth from serum, or plasma, we'd be very excited. I also have access to urine and saliva. I don't think we have stored sweat, but it would be, I'm just curious, if we could maybe, if there's other tissues that we could think about looking at PEth. You guys are the ones that know the answers to that. And I have great study teams that I've worked with on all this work in Uganda, at UCSF, in Boston, and elsewhere. Thank you.
That would be nice.
If anyone wants to answer my questions up there.
Thanks, Judy. I agree. I think it's quite normal that certainly the higher ones, the ones with higher PEth values, that they tend to underestimate. Typically, if we ask someone how much you drink, it's quite annoying to say 20, 30 units per week. It's like, well, yeah. I recall asking someone, do you drink? Well, I hardly ever drink, and then they said, 2 beers at noon, and then a few in the evening. But yeah, you really didn't consider that as important drinking. So yeah, people underestimate.
I really like the idea with the 50.
Of what?
The 50 nanogram as a threshold for the clinical relevant consumption.
I took that from Scott Stewart, who was publishing some early papers in the US of liver disease patients, and his 50 was about, in women, was about 2 to 3 drinks a day. So I thought, well, that's kind of what your guidelines are. Women should drink less than 2 drinks a day. So that's where I got the 50.
What I also want to say, we should also have a second low threshold, just not a 20 or 35, but we should have another one for these purposes of we don't need abstinence, and maybe 35 or 20 might be interesting for abstinence, but 50 would be something like, okay, it's okay to have 50. It's not damaging your health probably, but I think we should talk about this.
Well, in
later.
HIV, we would love abstinence, but we are realistic, and so we call it safer drinking.